Hello
Okay,
there.
hello everyone. Thank you for joining this evening's webinar, Mind the Bleep. We've got another psychiatry series webinar this evening, and Ahmed will be delivering that talk, so I'll hand over to you.
Thanks, Alexia. Right, my name's Ahmed. I am one of the core site trainees in North London, and over the next half hour, a whistle-stop overview, basically, of personality disorders, because in reality, this is a topic that, if we went fully in depth, could take a long, long time. Understandably, as probably quite a few of you watching will know, this is one of the most controversial areas within psychiatry, realistically, and it probably boils down to a bunch of reasons, including the fact that personality disorders, in particular emotionally unstable personality disorders, one of the most stigmatized conditions within healthcare. But to the core of it, when we're defining other conditions like psychotic conditions or even conditions in physical health, we know we have a clear-cut definition of what psychosis is, or what the heart's meant to do. But it's worth maybe just for the next 30 seconds or so seeing if you can think of what you think personality is and what's yours, if you've got a piece of paper, if you have, and then thinking how exactly do we get from that to then getting a clear-cut definition of what a disordered personality is. Ideally, you will have paused at this point to have a think about that, but when you unpause, we'll move on to the sort of textbook definition. And you can imagine it's very sort of sanitized and clinical, an individual's characteristic way of behaving, experiencing life, and perceiving and interpreting themselves, other people, events, and situations. A lot of words to essentially say just who a person is. But as we know, a disorder is something which disrupts a person's ability to function. So a personality disorder is something which leads to a disruption in an individual's characteristic way of behaving, experiencing life, and perceiving and interpreting themselves. And it is very disruptive. It can be very, very disruptive, as we'll touch on. But bearing in mind that our personality usually manifests in how we think about ourselves, feel about ourselves, but also how we interact with other people. So that's how these symptoms come across and how they emerge. It's very important, I think, when thinking about personality disorders, to be aware of how strong a link there is between experiences and personality disorders. If you think about it as they'll come about when someone's life experiences didn't support them adequately for essentially being able to manage in the world, whether that was due to significant traumatic events or parental neglect. That adversity in early life didn't equip them with the skills to be able to react and adapt to the things around us, including other people's behavior, life events, changes in the environment. So that's sort of the seed from which personality disorders spawn. And why they're important is they can complicate any other disorder they present with. If you've got a personality disorder alongside a physical, you can sort of, in terms of them affecting person's life, which is their personal functioning, how they look at themselves, but also family life, social life, I suppose, including relationships, both romantic and platonic, education, their work, and as we said, there are very, very stigmatized set of illnesses in the set of, if you have started working or maybe you've been on placement, if you're a med student, this heart sink that you might see in other members of staff when they find out that the next patient to be seen has got a personality disorder, bearing in mind that they have an illness that isn't their fault, but the way it manifests makes their ability to interact with other people very difficult, both for themselves and the people around them. So, moving on, want you to take maybe 30 or so seconds, pause this, to have a think about this. So according to the International Classification of Diseases, the 11th edition, which came out a few years ago, what's the minimum period of minimum duration that symptoms have to be present for in order for a diagnosis of personality disorder to be made? Is it 6 months, a year, 2 years, 5 years, or do they have to be present since adolescence? Pause, which is 2 years. Technically, the ICD-11 words is the disturbance has to have persisted over an extended period of time, but it does put in brackets, lasting 2 years or more. An interesting thing with point E, previously in ICD-10 and editions before that, there was an age cutoff of 18. You couldn't diagnose a personality disorder before the age of 18. Instead, if it was a child who showed signs of heading towards that, then emotional dysregulation was the common label used for it. The idea being that someone's personality hasn't stabilized by this arbitrary cutoff of 18. However, ICD-11 has removed basically all age limits for disorders. So technically, according to ICD-11, a personality disorder can be diagnosed at any age. Realistically, they're not, but something to bear in mind because it is a change in guidelines. So, in terms of diagnostic criteria, if you are looking at this from a clinical practice perspective, ICD-11 has completely revamped the diagnostic criteria for personality disorders. The DSM-5, the Diagnostic Schedule Manual for Mental Illnesses, which is the American classification system for diagnosing mental illnesses, and the ICD-10 had a very categorical point of view on personality disorders. They were discretely separated into 10 distinct disorders, which is very helpful for exam purposes, which is why if you're here because you're prepping for MSRA or for UKMLA or whatever your exams are, that's why most of this talk we're talking about the categories. Clinically, obviously that doesn't show, that's not particularly nuanced, and in real life these things do have nuance to them, which is why ICD-11 has shifted to a more dimensional view. So instead of there being 10 different personality disorders, as it was previously, in ICD-11 there is just personality disorder. First of all, you grade it as mild, moderate, or severe. Then there are 5 trait domains, which when we look through the sort of typical ICD-10 DSM classification of cluster A, B, C, you can kind of, if you have a think about it, you can kind of see how these transfer over, rather than saying this disorder or this person has obsessive compulsive personality disorder. It's they have personality disorder with these traits. So you might say this person has moderate personality disorder with detachment and dissociality. Because borderline personality or emotional unstable personality disorder is by far the most common one using the old classification system, and actually as a phenotype does link, it has relevance with treatment because people with that disorder have a particular gold standard therapy, dialectical behavioral therapy. There is a borderline qualifier that you can add on to the diagnosis of personality disorder, particularly for the purpose of going, this person might benefit from this particular therapy. If you're wondering about treatment, remember there are no medications that are technically licensed for personality disorders. Often the particularly serious cases will be on medication, but that's trying to manage symptoms or comorbid conditions rather than actually the personality disorder itself, and there's no solid evidence base for them. EUPD is the one that dialectical behavioral therapy is a gold standard for. If you're wondering what that is, it's a sort of building on cognitive behavioral therapy by this psychologist called Marsha Linehan in the second half of the last century, which consists of 4 domains which are particularly important in patients who have difficulties with labile emotions and fear of abandonment. So it focuses on mindfulness, emotional regulation, distress tolerance, and working on interpersonal relations. But if there's a question asking you about first-line management for EUPD, it's dialectical behavioral therapy. You might also come across mentalization-based therapy, which is also evidence-based for it. All the other personality disorders, mainstay is some form of psychological therapy, usually cognitive behavioral therapy, to varying degrees of success. Just for your awareness, basically, these are the essential criteria according to ICD-11 for the diagnosis of a personality disorder. Now, moving on, we are going to be ignoring ICD-11 because realistically, if you are sitting exams, people have not yet moved on to ICD-11 outside of personality. Them are still using. If you're sitting exams, they're still going to be asking you about emotionally unstable personality disorder, paranoid personality disorder, etc. Then probably will not have moved on to the newer system yet. So for the purpose of the exams and so on, we'll be talking about the old system. So another question for you, which is, which of the following personality disorders is thought to lead to an increased risk of being subsequently diagnosed with schizophrenia? Is it A, paranoid personality disorder, B, schizotypal personality disorder, C, schizoid personality disorder, D, antisocial personality disorder, or E, avoidant personality disorder? If you take a moment to think about that, pause if you wish, and then we'll move on to what the right answer is, and unpause once you're done. So the right answer in this case is B, personality disorder. So we'll talk about the cluster A personality disorders, but technically schizotypal is the one which seems to have the most solid relationship with schizophrenia, in that if you are diagnosed with schizotypal personality disorder, you're at a greater risk of going on to develop schizophrenia, technically. So moving on to cluster A. I don't want to be stereotypical, but unfortunately in SBA land, often stereotypes rule supreme. If you think of the example of unwell businessman, almost always leads to you having to think about HIV, for example. The cluster A personality disorders are generally described as the odd personality disorders. So the first one we'll talk about is paranoid personality disorder. Paranoid personality disorder is characterized by, as it suggests, intense paranoia. The pattern for it is pervasive distrust and suspiciousness of others, and interpreting their motives as malevolent. It'll usually start by the time that they are adulthood. There'll be very low, almost non-existent threshold for believing that someone has malicious intentions towards them, is plotting against them, and that inevitably affects their ability to trust other people and develop social social relationships. You can't diagnose it if the behavior is occurring during the course of a psychotic illness like schizophrenia or type 1 bipolar affective disorder, or if you can attribute it to an organic cause like temporal lobe epilepsy. But the things that make you suspect it is this excessive suspiciousness and hostility, hypervigilance as well. They may come across as cold. How they present to services, often they don't present to services because of this, because they don't trust other people. It might come across because they come for something completely different, which often is the case with most of the personality disorders. And then people realize, oh, there's something else going on here. They are a vulnerability of forming, maybe cults isn't quite the right word, but if you talk to one, they'll often tell you about being on online forums and so on, people who share similar ideas. They tend to be drawn to what others might label conspiracy theories. And there have been a few instances of the paranoia being intense enough that it can lead to violence. But that's your paranoid personality disorder. You can't really convince them that their paranoia is unnecessary or excessive, because to them it's entirely justified. Then you move on to schizoid personality disorder. The stereotype for this is the person who is detached from social relationships, doesn't really express their emotions much, doesn't take a significant amount of pleasure in social activities, preference for being solitary, indifference to praise or criticism. This tends to present because someone might think, oh, so and so has autism, or they might present because other people are worried about them, thinking, my son or daughter is a loner, for example. But again, they rarely present with this as their primary complaint. Difficulty expressing emotions like anger, so again, they can come across as cold. Interestingly, it can also the early, like the prodrome for schizophrenia or for primary psychotic disorder, can kind of mimic it, because people become quite socially withdrawn. Importantly, people can get very brief psychotic symptoms during periods of distress. They're quasi-psychotic symptoms, really. And their functioning is only really impaired if they're forced to work with other people. They might actually do really well when they're isolated, but yeah, when they're stressed, they might get sort of psychotic symptoms. Finally, schizotypal personality disorder, which is actually quite controversial because it's been moved to schizophrenia-like disorders in the most recent versions of like in ICD-11, not ICD-11, sorry, ICD-10, I think. The thing that you might see in an SBA prompt or something is magical thinking, so on, but it's the one which almost has some of the to psychosis features, like perceptual abnormalities. So people might think that things are referring to them, but not to the point where it's a delusion of reference, to a point where they might be able to accept that that's probably not about me. Illusions rather than hallucinations. They might also be a bit paranoid. They might come across as thought disordered in terms of their speech being odd and circumstantial, but again, you can kind of understand where they're going, unlike with somebody with true, fully fledged thought disorder. But one of the hallmarks is that they are acutely uncomfortable with close relationships, but particularly because of the difficulties that come with the eccentricities of their behavior. The other thing that you might see is quite supernatural thinking about things, but beyond what's normal for their culture or their environment. Very magical thinking, some bizarre fantasies, but again, not to the point where it's quite delusional. But you can kind of see, because this one is closer to schizophrenia, why it's been shifted. It doesn't really fit in with the others because the symptoms do actually walk on the tightrope above true psychotic phenomena, and can split into it because it is fall over into it because it is linked to it genetically. So as your cluster A personality disorders, to summarize: paranoid in an SBA, they don't trust other people, and have a very low threshold for believing that someone's persecuting them. Schizoid has or seems to have no interest in social interaction, does better when alone. Schizotypal, magical thinking, almost at the threshold for psychosis, behaves in a way that other people might think is quite odd. Moving on to our cluster B, our preceding question: what proportion of patients with emotionally unstable personality disorder die by suicide? Is it 0.5%, 1%, 2.5%, 10%, or 15%? Pause, come up with your answer, and then unpause. So the answer in this case is D, 10%. I've put this question in for a particular reason, which is especially once you start working as a doctor, there is the idea that patients with emotionally unstable personality disorder, it's all attention seeking, and they will not actually do something serious. But estimates are 3 to 10% will die by suicide. In some of those cases, it's thought that it might have been accidental, because often one of the defining traits in EUPD is self-harm, but not with the intent to end one's life, but distressing, afraid that people are going to abandon you, that people that you do love don't love you, feelings of emptiness, lack of identity, very difficult to control one's emotions on the background of often very severe trauma in childhood and adolescence. So the suicide rate is present, and it's not insignificant. It's, as with suicide in general, more common completed suicide in men. So it's thought from a separate study that is about 18% of men with EUPD might die through suicide, and half of people who die through suicide are either in retrospect or at the time diagnosed with a personality disorder, the majority of that being EUPD. So yes, they may often present to services with self-harm or saying that they feel suicidal. Do be on the safe side, don't dismiss it out of hand. A significant portion do go on to die by suicide. So our cluster B has 4 disorders in it. Our first one is the antisocial personality disorder. Pause at this point as well. There is a child and adolescent diagnosis which is linked to antisocial personality disorder when the child grows up and becomes an adult. Give yourselves a few seconds to think of it. Pause, unpause once you have come up with an answer. So conduct disorder in childhood is commonly associated with antisocial personality disorder. The hallmark of antisocial personality disorder is just a complete lack of regard for others, their autonomy, their belongings. It is very common in prison, which isn't really a surprise, but can be linked with sort of petty offences such as robbery and so on, all the way to the quite severe ones of murder, for example. Can sort of, I suppose, respond to therapy if, especially early on, if it's whilst they're a child and there's sort of intense multidisciplinary work whilst it's conduct disorder and not yet antisocial personality disorder. But if you ever end up working in like a male psychiatric intensive care unit, for example, this will be a very common presentation. Emotionally unstable personality disorder, frequent self-harm, often not with the intent of ending one's own life, but with sort of used to try and temporarily manage distress, feelings of emptiness, impulsivity, which can often be associated with heavy substance or alcohol use. This is your classic SBA is person who cuts themselves and so on. Usually, what's the first line treatment for it, which, as we said, is dialectical behavioral therapy. But bear in mind that this is an incredibly unpleasant condition to have, made worse by the fact that because of how difficult it is to interact with the people around you, the people that you want to go to for help end up not wanting to help you because they find it unpleasant being around you, which makes it even worse of a condition to have, essentially. Narcissistic personality disorder, fairly self-explanatory in the name. The thing to remember with that is often they present with depression. And when you unpick it a bit more, you find out that their depression is because they feel appreciated, the idea of the inflated sense of self. So if you're wondering how it ends up diagnosed, it's usually because they've come with depression. Similar with histrionic personality disorder, but that leans more towards anxiety. The stereotype for histrionic personality disorder is the attention seeker, the drama king or queen. words you might see in an SBA are sort of inappropriately seductive, something like that. They want to be the center of attention. Again, not particularly from usually stems from an underlying insecurity and need for, or perceived need for, validation from others. And usually, if you delve into their background, there is an element of neglect. Often, they will present because of anxiety or depression. Usually. Finally, here is the predisposing question for cluster C, which is you've got a med student and they ask you how to differentiate between obsessive compulsive disorder and obsessive compulsive personality disorder. Which of the following would be the single best differentiator? Would it be that hoarding is common in OCD but not in OCPD? Would it be that self-criticism is seen in OCD but not in OCPD? Is it that obsessive cleanliness is common in OCD but not in OCPD? Or is it that thoughts and behaviors in OCPD are egosyntonic, whereas in OCD they're egodystonic? Or is OCPD associated with a higher suicide rate than OCD? Pause, give yourself some time, unpause once you have your answer. Now that you're unpaused, the correct answer is D. So in OCPD, thoughts are egosyntonic. The person's distress is usually because they feel like they are falling, that their people aren't doing things to their standards. They're not perfect. They're not doing things perfectly, but they believe that their thoughts make sense. There is no intrinsic distress from their thoughts. Whereas in OCD, the obsessions are incredibly unpleasant and egodystonic. If you're getting intrusive thoughts telling you that you're going to die from sepsis or that you're a pedophile, it's hugely, hugely distressing. Going through the other ones, hoarding can be a feature of both. Self-criticism, both as well. Obsessive cleanliness, again, can be seen in both, but the reason's different. In OCD, the cleanliness might be because of fear of contamination, whereas in OCPD, it's a need for perfection. And OCD's got a significant suicide rate. It is a horrible, horrible illness to have. So, finishing with cluster C. So the first one we'll talk about is avoidant personality disorder. So this is characterized by feeling very inadequate, hypersensitive to negative reactions from other people. And that leads to avoidance, avoiding activities that might risk significant interpersonal contact because of fear of being criticized or rejected, unwilling to get involved with other people unless they're certain of being liked. And then that leads to things like restraint with romantic relationships because of the fear of being shamed or ridiculed. They can be very preoccupied with being criticized or rejected, and they think of themselves as socially inept or inferior. They will not take personal risks because they are so worried about being embarrassed. Again, you can often trace this back to a background of usually like a difficult childhood, and it's disruptive because you might not go to a job interview because you're worried that you're not dressed appropriately. You struggle to go out and make friends, for example, because you're worried, what if things go wrong? They will often present with low mood because of isolation or with features of social anxiety. And then you sort of get to it because they're not responding to your standard treatment for anxiety or depression and on. Then dependent personality disorder. This is characterized by there is a person that the patient is dependent on. They find it very difficult to make everyday decisions without excessive amount from others. Usually they need other people to take responsibility for most big areas of their life. Difficulty expressing disagreement with others because of fear of loss, starting things on their own because they don't have self-confidence. And so not because they're not motivated or don't have energy, but because they don't have confidence in themselves or their own judgment, they'll go to really excessive lengths to obtain support from others to the point of volunteering to do things that they don't want to do purely to get support from others. And when they are uncomfortable because of this fear of being unable to care for themselves. if a relationship, whether that's a friendship or a romantic relationship, ends, they will practically urgently seek another relationship because they cannot tolerate the idea of being left to fend for themselves. So again, this will present with anxiety or depression, which then doesn't respond to treatment, which is the case for practically most of the cluster C ones, but also the case for narcissistic personality disorder, histrionic personality disorder, and even in some cases emotional unstable personality disorder, because the first presentation might be low mood, or thought of as low mood or anxiety. Oh, whoops. Antisocial personality disorder usually presents because the person has done something, often ending up in involvement with the police usually, or if it's earlier on, problems at school or university. Finally, finish with obsessive compulsive personality disorder. This is a preoccupation with perfectionism, with order, with control, basically. It means that the person loses flexibility, the ability to be open, and it really affects their efficiency. So it'll mess with work or mess with relationships. They will, prioritize perhaps work and productivity over friendships, over leisure activities. They can also be very, very inflexible on things like morals or ethics or values, to the point that you can't account for it because of their religion or culture, but very rigid in their thinking. The hoarding comes from being unable to discard objects even when they have no sentimental value. Also, they will not delegate things to other people, so they'll very much struggle in things like management possessions. The other thing that might come up in SPAs is they often don't tend to spend money. Their worry is money is something that needs to be kept in case there is a future, like a catastrophic future event. So you might hear them described as miserly, or yeah. So the thing is, they see these thoughts as normal, understandable, unlike an OCD. They're very, very. Brings us to the end of our whistle stop. Just remember, if a question comes up on them, they will often follow a very clear-cut stereotype. If they mention treatment, ask about treatment for EUPD, they're talking about dialectical behavioral therapy. If they ask which one's most associated with schizophrenia, schizotypal personality disorder, and if they ask what's the difference between OCD and OCPD, there are many, but the one that they're looking for is in OCD, they're very distressed by the thoughts, whereas in OCPD, the distress comes from the consequences of the rigidity of their behavior. That brings us to the end of the talk, a few minutes over, but if you have any questions, please do email me, and thank you for watching.
Thank you so much, Ahmed. That was really great. If everyone who's either watching live or watches this at a later date, please scan the QR code. There's also a link in the description on the YouTube video that you can click to give some feedback. You can also get a certificate for your time. We really value any feedback that you can give. But thank you so much for watching, and I hope everyone has a nice evening. Thank you again, Ahmed.